Alright, so now we're going to talk about the wandering atrial pacemaker. Now, this one is called a WAP. No offense to anybody. W-A-P. Now, this one, the way you'll recognize it is that it's always going to look different. It's wandering. It's wandering around the EKG. So you never know where it's going to come. It's also wandering around the heart. So it's going to look different. It's like, woo-hoo. It's going to look just like that. But it's always going to have a P and a QRS and a T. So just know if you have it and it's looking all funky. And I think it's also an irregular beat. Let me see. It's usually 60 to 100 and faster. Then it's multifocal, usually a regular P wave, but can be AB junction 2, narrow QRS, that's important. So I think the wandering atrial pacemaker is pretty much a regular beat. The important thing to know is that it just is going to look very different. Then you have a multifocal atrial tachycardia. That one is going to be looking different. Remember, multifocal is going to be different points of the heart that's coming from. If it's coming from different points, then it's always going to look different. But it's a tachycardia, so that one is going to be above 100 beats a minute. That one is going to have P waves. Now, I found this confusing. I had to write this on my note. Multifocal atrial tachycardia is not atrial fibrillation. Now, it is coming from different points in the heart, but every P wave is going to correspond to a QRS wave. So even if it looks funky and every one of them looks different, there is going to be a P and a QRS. However, with AFib, the top of the heart is literally going like this. So there's not going to be a QRS for every P. So that's the difference between the two. Let's see. So basically, the multifocal atrial tachycardia is the same as the wandering atrial pacemaker. It's just faster. But you're going to see a QRS for every P. Let's see. So things that you can do for this. You can do vagal maneuvers. Just think of this lovely face whenever you think of vagal maneuvers. You can tell them to bear down. That's gonna touch their vagus nerve or whatever, and it's gonna help slow down the heart rate. I've actually seen it happen. It does work, and it's something you don't necessarily need a doctor's order to do. You just tell them to bear down a little bit. And if they're a baby, you're supposed to take ice and put it on their face. I guess it makes them go, whatever. It sounds good. That's what you do if you see them in like a crazy tachycardia. I mean, nobody likes to see 120, but if they're going like 200 beats a minute, it's like, would you bear down for me, please, sir? Also, if you have IV access, you can administer adenosine. Now, of course, if you see a tachycardia anywhere, you're gonna, sir, are you okay? Check for a pulse. Are they breathing? Don't forget your ABCs or your CABs now with the new stuff that they passed. Whatever. So let's see. What can I? Supraventricular arrhythmias begin above the bifurcation of the bundle of His. We know that. Supraventricular. Atrial tachycardia is an irritable site in the atria, and it fires automatically at a rapid rate. The atrial tachycardia is not going to look like the multifocal atrial tachycardia, and it's not going to look like the wandering atrial pacemaker, because the atrial tachycardia is going to be a fast, but they're all going to look similar because they're all coming from the same one irritated spot. The wandering is wandering, and the multifocal, multi. So just remember those things, and so remember it's going to be different. Now here's something fun that people just want to talk about. Let me see. Let me go over this. Oh, so atrial tachycardia, things that you want to do. Like I told you, you're going to do your ABCs. Also, don't forget to get vital signs, because you want to make sure their blood pressure isn't like 10 over 20. That's horrible. They're dead. Um, you want to make sure that they have blood pressure. You want to make sure that they're breathing before you go talk to the doctor. You don't want to go talk to the doctor and he comes back and the patient has no pulse, because then you will look like an idiot. So, like I said, your pulse ox, if they're not saturating good, you want to throw some oxygen on there. You want to get your vital signs. You want to get your 12 lead. You want to make sure that you have good IP and IV access. Try your vagal maneuvers if they're not hypotensive. And when you're going to give your medications like your adenosine, your calcium channel blockers, your beta blockers, you're going to talk to your doctor first. But sometimes when you do ACLS, they're going to be like, you just do that, you know. But in your practice, you make sure you ask the doctor before you go give an adenosine. Just saying. So atrial tachycardia, like I said, is going to be a P wave before every QRS, and you're going to see it's going to be going at about 150 to 250 beats per minute, and they can really get that fast. So here's something fun. Atrioventricular nodal reentrant tachycardia. I know you must think this is stupid. I actually have to know this stuff. So this stuff is caused by reentry. Reentry, I used to think, I didn't know what the hell people was talking about, and they used to be like, it's reentry. I'm like, what is that? What do you mean reentry? Reentry just means, like, in this person's heart, there's a cycle of, like, instead of their conduction going straight from the sinoatrial node to the atrioventricular node, it's going in this weird way, and it's like a circle. So once you kind of enter into it, you can't get off. So it's like, and it just keeps going, and it's usually in a really fast rate, and you can't really stop it. And the reason why you'll notice it, I think, is because they said the P's will be inverted, because the electrical conduction is going, you know how I said that circle? It's going back up. It should be going continuously like this. But now instead of going continuously like this, it's going back up and re-entering into that sinoatrial node, or wherever that irritable focus is, and it's starting that cycle again. So it's usually started by a PAC, and you'll have something that comes really fast when it's not supposed to, and then the P will kind of be upside down, or I think the P even will maybe, I think it'll disappear a little bit, and it's just going to be like, and it's just going to keep going. It's going to be very annoying to you. This rate can be from 150 to 250 beats per minute, and this is all still the same stuff. You know, you're going to be like, sir, are you with me? Check for a pulse. Make sure he's breathing, taking breaths. You know, if he's satting 76 on the monitor, might want to put some oxygen on him. But make sure you put that pulse ox on him, because you're not going to know what he's setting if the pulse ox is not on there. You want to get a set of vital signs and make sure his blood pressure isn't 20/10. And you want to make sure your IV is patent. You get that 12-lead EKG, go over to the doctor, so-and-so, this person's having atrioventricular. Dare you to say that to a doctor. He would probably be like, GTFOH. Doctor, this patient is having an atrioventricular nodal reentry tachycardia. Here's the EKG, and here's the last set of vitals. He'll be like, give her a raise. And remember to try your vagal maneuvers, and you want to probably think about getting cardioversion stuff set up for the doctor. He would be so happy if you did that for him. And that said the P, like, so the P, I thought it's upside down, but my notes are saying that it typically distorts, it's buried in the T, and it distorts the QRS. So if you see like a narrow QRS situation going, but something about it just looks like a little lumpy, a lot of times that's that P. It's actually buried in the complex. That's really annoying, and it's really hard to read and not think of it as like some kind of, you know, aberrancy or weird heart rate, but it's actually just the P doing its own thing.